ready for you? We can start.
No, you start. I'm not turning this off. Being a Georgia fan is the worst thing in the world. It's a failure.
Okay. Good afternoon, everyone. I think we're going to go ahead and get started because this morning when we got the late start, it's just kind of perpetuated it. So I'm going to go ahead and I believe start with the questions and answers. And as people drift in, we picked up the index cards from the tables, but if you have a question that did not get picked up, just kind of hold it in the air and somebody will come around and get it. Let me say at the outset, though, of this that we had intended to put a flash drive into everybody's tote bag yesterday that has every single PowerPoint, all the articles, and other stuff in it. And yesterday, when we checked on them, they were in China someplace. They had not made it to the United States yet. They are in the United States, but they're not going to be here probably until Monday. So we've got a couple board members on their way to buy some envelopes. We're going to be passing envelopes out. We want you to address them to yourselves, and then we'll give you at that time a return address. Either put your own on there as a return address also, or we'll give you the coalition address. But before you leave here, we need an address, at least one per family, that you'll be able to see all these presentations at home. We apologize. We didn't know we were going to do the Around the World in 80-day tour with our flash drives. So if you have any other questions, we've just got a couple more. So as you think of them, just hold them up, and there'll be a research question and answer session a little bit later on in the day. So right now, I'm also going to let the docs introduce themselves as we do it, because with a name like Biedenharn, I don't want to screw their names up as bad as I screw my own up sometimes. So here you go. Thank you.
So I'll start down here on the end. Again, I'm Dr. David Houghton. Thanks so much for enjoying the yesterday and the morning with us so far today. This is our Ask the Doctor or Stump the Chump session that I think is a good idea to follow after you've heard some presentations this morning. I'll let Dr. Abisamra again introduce himself, and we have Dr. Daniel Clausen joining us up here. Dr. Lee had to go home to be with her family for the afternoon, and so he's filling in admirably here in advance of his next talk, which will be in just a few minutes.
Thank you, David. I'm Freddie Abisamra, and I'm a cardiologist, electrophysiologist with interest in autonomics, and I work at Oxnard Clinic too. So.
Hi there. My name is Daniel Clausen. I'm at Vanderbilt University in Nashville, Tennessee, and I take care of patients that have neurodegenerative disorders. MSA is one of them. And later I'm going to speak to you about clinical research and kind of what are the current ideas in terms of trying to find a cure and trying to improve symptoms with MSA. But for this time, I'll try and answer your questions as best as I can from a neurologist's perspective.
So I'll start with the first question here. This one says, stories have been told about the beneficial effects of exercise, such as boxing and bicycling. Please tell us about this. So I think it brings up a great point where we talked about the multidisciplinary rehab model in management of early and late MSA. And particularly, as Dr. Clausen and Dr. Perez may talk about with some of the other novel therapeutics and clinical studies that have been shown, we don't yet have something that is definitively neuroprotective. That being said, there look to be some significant benefits with exercise in the way that it helps improve brain health. And the presumption, of course, is that the Parkinsonian conditions like Parkinson's disease and MSA fall within that beneficial umbrella. There have been good studies that have been done in animal models that have been designed to show an increase of a couple of growth factors in the brain after exercise. One of them is called GDNF, or glial-derived neurotrophic factor. Recall that it's the oligodendroglia that are largely affected in MSA. And also BDNF, brain-derived neurotrophic factor. This is essentially fertilizer for the brain. We know it's improved and increased with a regular exercise program, 30 to 40 minutes, 3 to 4 days a week. And so we do recommend that somebody take advantage of those. Particular to bicycling and boxing, there's great data right now that show that those are popular and easily performed in our patients with Parkinson's disease. I don't think there's anything unique to boxing or unique to cycling per se, other than it takes advantage of both speed and amplitude. We know that we want things to be speed-based, so do things faster, and we want things to be amplitude-based, so to do things bigger. Move along.
I guess I'll take the second one. This says, complaints of dizziness and chest pain, went to the ER, blood pressure on arrival was 90/70, chest pain subsided, blood pressure when lying down was increased to 140/94 plus. ER physician is not concerned with blood pressure increase, not familiar with MSA, lab were good, diagnosed with reflux. Could this possibly be cardiac related? How to follow up, how to be proactive with MDs and not familiar with MSA. So, it's obviously difficult to say without seeing the patient directly, whether the chest pain was cardiac, but it can very well be without, being cardiac the way you think about it, where you're having an obstruction in one of your major coronary arteries that could lead to a heart attack. The fact is, like any other organ, the brain, the kidneys, the heart likes to have blood to perfuse it. So if your blood pressure is very low, you will actually have, a paucity of oxygen. So the increased demand of the contraction of the ventricle will actually cause you to feel symptoms of angina like chest pains. If an angiogram gets done, it may very well be completely normal. Still, the angina could be, the chest pain could be, coming from the heart. Now, typically, if you actually, when you lie down, your symptoms would go away, your chest pain goes away, that's quite likely to be, because your blood pressure picked up and it is a demand chest pain as opposed to something else. It's quite unlikely to be a reflux. If you lie down, it tends to be worse. So.
I have a number of questions here, so I'm going to start with the easy one. This one is it important to see a neurologist post-diagnosis and why? So if you look at a disease that's similar to MSA but a little different, Parkinson's disease, it has a similar protein that basically gets clumped up, alpha-synuclein. If you look at patients who see movement disorder neurologists, they tend to do better. So when you go to a person that has expertise in a certain disease, it's usually you get better outcomes for patients. And so the answer to that is it's probably good to see a neurologist, especially one that has an interest in MSA. They may not know everything about it, but they can learn. And my counsel to patients is that it's good to establish a relationship with a neurologist who can help manage the very complex symptoms that you may have. Because if you think about MSA, you have symptoms related to autonomic problems, sleep problems, rigidity, sometimes dystonia, forced muscle contractions, and then progressive other issues. So my counsel is to find a neurologist that you like, that you trust, and work with them.
Good advice. So that's a good segue to some of the more complicated questions that I have with relation to the cognitive impairment. And I've got a couple of questions here. I'll sort of put them together. So one of them said, is dementia with Lewy body something that is seen with MSA? And from a diagnostic perspective, if you've already had a DAT scan prior to diagnosis, should you also consider a PET scan? And then there was another one sort of in that same vein that talked about the fact that several medicines that are typically used for Alzheimer's disease were discussed, and why would that be needed in MSA, and is dementia common? So the historical thought on MSA is that to have features of the traditional cortical styles of dementia, things where you have significant loss of memory or loss of awareness, loss of recognition of friends and family, the inability to continue to pay your bills or organize your life, is really a disqualifying factor for MSA. So that's the traditional approach. What we also recognize is that some patients with MSA would get a little bit slower with their thinking. They would be a bit more inattentive or have worsened concentration, more difficulty with multitasking. That's changing a little bit. There have been a couple of papers that have been published in the last couple of years that have indicated that the risk of having more cognitive changes in MSA is probably greater than what we earlier realized. Part of that might just be lack of recognition on the part of scientists and physicians to see it. Part of it may be that patients with multiple system atrophy are living a bit longer, and so that the longer that they live with good supportive care, as all of us are trying to provide in this room, some of the other cognitive changes may be more likely to rear up. And so that might be the other reason that we're seeing a bit more of it. From a diagnostic perspective, I don't believe there is any diagnostic utility, though, at this point for adding on a traditional PET scan. Traditional PET scan utilizes sugar as a form of energy in the brain to show the areas that are active or hypoactive. Now, that's different in research. So you saw last night with Dr. Vernino's talk, where they've done some very important work at UT Southwestern with some PET scanning to try to recognize which parts of the brain may be more or less affected with different subtypes. But in the typical clinical sense, there's not a lot of utility right now for PET scans. And with regards to the medications, the reasons that we fall back on Alzheimer's medicines is that those medicines are the ones that are labeled as such by the FDA, because that's where the greatest number of patients were tested on those drugs to get the indication. But as you probably have heard from your physicians and are aware of, all of us up here use things off-label all the time, and so we recognize there might be an advantage to using an traditional Alzheimer's drug to try to boost memory, whether it be an MSA, Parkinson's disease, progressive supranuclear palsy, or any of the other types of disorders we've talked about today. Freddie?
Okay. So this next one is risk versus benefit on long-term warfarin for a history of DVT, that's deep venous thrombosis, but now with increased falls. If needs to stay on anticoagulant, is there a better medication recommended in the MSA patient? So yes, nowadays we actually have more than one way to treat DVTs. You've all heard, about the new oral anticoagulants. They're all over the place on TV with lawyers saying they're bad for you. The only reason they say they're bad for you is because they're new drugs that are actually still not generic, and therefore the companies can be sued. These drugs have been extremely effective in decreasing, their biggest use is for patients with atrial fibrillation, but they have a lot of indications that have been FDA approved for other coagulation issues, including DVT. Just to put this to rest, when you compare the new oral anticoagulants against Coumadin in the atrial fibrillation population, there's a significant advantage to be on the new oral anticoagulant. They are actually, saving a lot of strokes, even over Coumadin. So whatever you hear on TV, ignore that. That's just people chasing money. As far as DVT is concerned, in general, people should not be on anticoagulants forever. Unless you have had recurrent DVTs and or you've had pulmonary emboli, the treatment should be somewhere between 3 to 6 months. The recommendations change from year to year, to some extent, but in general, no longer than 6 months unless you have either a very genetic tendency towards it or you do have recurrent events. And yes, you can actually switch to another anticoagulant. Those other anticoagulants tend to cause less bleeding in general. The major benefit is that they're associated with less bleeding in terms, especially for the very serious ones in the brain. The ones that seem to be, quite effective and actually safe for DVT would be probably what you hear, Xarelto and Eliquis. That's apixaban for Eliquis and rivaroxaban for Xarelto. If you have kidney disease, then maybe that's not those are not the drugs of choice for you. Otherwise, it's easier. You don't have to keep constantly worrying about your other drug intake, your food intake, your greens. These are just one-size-fits-all medications. One caution, so Eliquis is twice a day. Rivaroxaban is once a day. But if you take the dose that's greater than 10 milligrams, you should have it with a meal at night, because then biological availability is a lot better then, and so therefore it will be a lot more effective.
Great, thank you.
Keep it rolling.
Go ahead, yeah.
All right, so I'm going to combine two questions. The first one is regarding the use of Sinemet, which is, if you don't know, it's the medicine carbidopa levodopa. It was mentioned earlier today. And this is the medicine that increases dopamine in the brain. And then the question is, why is Sinemet effective in some symptoms of MSA? And how long does this last? And the second question is, in terms of getting more stiff, difficulty walking, turning over, what do you recommend for medications? So, as I said earlier, the difference between MSA and Parkinson's disease is really where the degeneration in the brain happens. And in MSA, a lot of patients have degeneration in the same part of the brain that Parkinson's patients have. And that part of the brain is the part of the brain that makes and uses dopamine. And so when you give a patient dopamine, their symptoms can improve. And the main symptoms that tend to improve are slowness of movement, rigidity, and tremor. And sometimes gait instability can improve as well, but not always. So it's very common to have a patient who has MSA to be on Sinemet. But really, the reason they're on it is so that their symptoms of rigidity, slowness of movement, those symptoms can be improved. The challenge we run into clinically is that dopamine medications can also lower blood pressure. And the example of that is these dopamine agonist medications like pramipexole or ropinirole. Those are notorious. When you give the patient those medications, your blood pressure can go down. And so what I tell my patients is it's kind of like that fairy tale Goldilocks and the Three Bears. You want something not too hot, not too cold, but just right. And so through trial and error and through dosing regimens, you try and improve the symptoms. Now, when it comes to walking and mobility, as was raised in the second question, sometimes you can get a benefit from Sinemet, and it can actually improve some of the rigidity in your legs, and you can walk a little better. But one of the challenges that we have in MSA is that what we call postural reflexes, that is the ability to right yourself when you are tipping over, that reflex goes away. And so perhaps if you have seen a patient with MSA fall, they tend to fall backwards. It's because they can't quickly right themselves if they're off balance. And that symptom is notoriously not responsive to dopamine. Sometimes it happens, but it's more rare than common. And so in those kind of cases, we are a little stuck, so to speak, in what to do. And so there is some emerging research, which is very interesting, and that's part of one of the studies that I'm doing, is where if you replace norepinephrine, which is a cousin to dopamine, it's possible that if you replace it in the brain, you can actually improve some of the postural reflexes, and we're testing that experimentally. There's also been some reports of using a medicine that's commonly used in Alzheimer's disease called donepezil or Aricept or acetylcholinesterase inhibitor. Those medicines have, in some cases, improved postural stability. And so when you work with your neurologist about kind of trying to sort out what symptom might respond to medication and what symptom won't, those are the types of medicines you may try or you may not try. And when it comes to the fact of why does it stop being ineffective, well, as the disease progresses, it's not just the dopamine-mediated nerves that are succumbing to degeneration. It's other nerves, and that's kind of why you kind of see a progression of early on. You may have a nice symptom response to dopamine, but as the disease progresses, you may not have that dopamine responsive symptom. So it's not as complicated as you'd think, but just kind of learning the nomenclature, learning the terminology, the parlance of this field really helps you kind of understand why or why not a medication might help you.
And I've got a couple of good questions that follow up to that. So one patient says, I take Sinemet for the stiffness, but when I increase it, I get a headache. Any suggestions? It's interesting. It could be from a couple of things. One of it may be, as Dr. Clausen had mentioned, the blood pressure going down. Sometimes patients don't think about that, but particularly in MSA, there's a lot of this coat hanger sign, some stiffness in the neck, stiffness going up to the posterior back part of the brain, pain going down into the shoulders, and that may be the headache that you're demonstrating. And so I would recommend that you check your blood pressure as you're taking those increased doses of Sinemet. It's also possible that you just have an intolerance to the drug. A certain percentage of patients taking Sinemet at high doses will develop headache. A similar question was, well, when the Sinemet doesn't work, what other medications are useful for the tremor, particularly the tremor of the MSAC variety? So as you have cerebellar degeneration or olivopontocerebellar degeneration, along with having some tremors at rest, patients will also sometimes have a postural tremor and what we call an intention tremor. So as they reach for something, the tremors get larger, and as they get closer to their body, it gets larger. But in the middle, it calms down a bit. Unfortunately, there's not a large number of medications that are very successful with suppressing that by much. There's some exceptions. Some patients will respond well to a medicine called baclofen, which is also utilized for muscle stiffness and spasm. So it's a medication that I will tend to use in my MSAC patients. There's a medicine called gabapentin or Neurontin. There's other forms of that can also calm down that tremor a little bit. And then we sometimes will borrow drugs from the essential tremor literature, which is a different disease altogether. The most common movement disorder that we likely see happens either in young adulthood or sometimes as an age-related phenomenon as patients get older. These are medicines. There's one called primidone that may be effective. There's one called topiramate that may be effective. And we tend to shy away from the beta blockers, a drug called propranolol or Inderal, because of what it can do to subsequently lower blood pressure, which then gets us in a greater stick than we were in the first place with MSA altogether. I will say that I have a handful of questions here related to drug development and its studies, so I'm going to save these for our next panel, which will occur after we hear the next three talks. Couple more.
Yeah, just to make a little comment about the beta blockers. So it can work both ways. Beta blockers have been released to treat hypertension on the basis of a very low difference in systolic blood pressure and like diastolic blood pressure in very large populations. I think it was a 10/5 decrease. Physiologically, beta blockers have effects that are actually counterproductive to treating hypertension effectively. So sometimes they can actually cause venoconstriction, and that could be helpful. So for some people, they can drop their blood pressure. It may not be effective. For others, it could be helpful sometimes. It's worth a try, though. I don't think it's for everybody. I have another question here, and says, do you have any recommendations for bed pillows, devices to elevate the head/torso in bed? So as I said earlier, I don't think elevating the torso is actually, what we're trying to look for. We want to elevate the whole bed. So either one of those, more expensive new, gizmos where you have the whole bed, kind of similar to hospital bed, but you have them also for, regular, you go to a mattress shop that, gets the high-end beds, and you have beds that lift easily with controls. Otherwise, the cheap way of doing it, you go to Home Depot, you ask them to give you blocks, 6-inch blocks that are wide enough, you put them under the head of the bed, and the whole bed is tilted. As I said earlier, that gives you the advantage of actually unconsciously using your legs to not slide. So that keeps your your muscle tone a little bit higher. It also decreases your kidney excretion of urine, and you'll be less hypotensive in the morning, less dehydrated. It also, by tilting you up, decreases your blood pressure that tends to be higher if you are supine.
Why don't we do one more question at
All
the
right.
end, and then we'll move along with our afternoon session, being aware that we will have other opportunities to answer questions later in the afternoon.
Last question I got, well, two of them, because they're sort of related. One was a question about depression medicines. Does that interfere with the absorption of dopamine medications? And the quick answer to that is not really. However, the tangent that I would go off on that medication question is one of the key differences between MSA and, say, Parkinson's disease-related autonomic dysfunction, blood pressure drops, is that the location for MSA-related changes is in the central nervous system, whereas the location for Parkinson's disease and DLB probably, and this other disease called pure autonomic failure, is usually peripheral. And so there's an emerging research to try and say, can we increase neurotransmitters in the brain, not necessarily in the periphery, but in the brain, to modulate blood pressure regulation. And I'll talk about at least two of these areas of research which have some very compelling results. And when it comes to antidepressants, some of these antidepressants have a norepinephrine effect. So for instance, atomoxetine, which I'll show you some information about, is a pure norepinephrine transporter inhibitor. And it shows that when you give an atomoxetine to a patient who has low blood pressure, you can actually increase the blood pressure, and you can actually improve orthostatic hypotension. And there are some other medicines that are antidepressants that also work like that, like venlafaxine or Effexor has a norepinephrine component. And that's kind of an emerging area of interesting research, is another tool to improve blood pressure control in patients. Again, the key point is that the location of where the problem is in MSA is different from the location of where the problem is in, say, pure autonomic failure. Two sort of different diseases. They share a similar pathology, but where the pathology exists is different. And so one of the medicines that we know crosses the blood-brain barrier is a question about Northera or droxidopa. So it turns out that droxidopa is a medicine much like levodopa in that it's a precursor to norepinephrine. And so when you give a patient droxidopa, it actually gets into the brain and can affect the mechanisms of the brain in a noradrenergic or norepinephrine-based mediation. So that's another type of medicine that can be used to improve central norepinephrine control. And so a lot of our patients will come in on, say, fludrocortisone or midodrine, and they'll have problems, and we'll add on medicine like droxidopa. That's very common. Vice versa, a patient will have early symptoms, and they'll be given droxidopa to begin with, and they'll add on another medication. So you use all these medicines, as I said earlier, the Goldilocks analogy, to find just the right temperature. And so that's kind of how we use these medications.
And I respect Dr. Abisama. He could not let two questions go. So
Yeah.
so we will get two
So-
more answered here, and then we'll move on.
Because these are a bit different. You know, this one says my blood pressure machine takes pulse and intermittently arrhythmia has been detected. Some MDs have picked up on it but blew it off. Should I be concerned? So it all depends on, you know, whether your arrhythmia that's being picked up is very repetitive and whether it actually is occurring with some symptoms. If your blood pressure machine has a very hard time getting you a pulse every time the pulse is different, you probably have a condition called atrial fibrillation, which can be very serious, but can be also very asymptomatic. Still, it is something that has to be tended to because most people will have an increased risk of stroke for that, and they will require to be on blood thinners. So it's easy to check, just an EKG, it's done. On the other hand, if you get, you know, one blip here and there and it doesn't bother you, forget about it, don't bother about it. You may actually, if you mention it, you may actually go down the, you know, the path of having so many tests that are unnecessary. The other question is about drinking water before standing or eating a dill pickle. You know, I think, you know, anything that increases your volume, anything that increases your sodium intake tends to help. But just doing that immediately before standing probably, you know, doesn't give you enough time to, you know, to fill up your vasculature. So you might want to give it some time.
Great. Thank you very much to my panel, and with that, Dr. Abisamra and Dr. Clausen, we appreciate you. Thank you.
Thank you.
Would you like me to speak from the podium?
Whatever you're comfortable with.
And if so, do I move that over?
Where was You want to get there so you can look at it?
Probably need to look at it. Can I undo it? Oh, no, I can't undo it.
Let's see.
I'll just stand here.
Hold it. I should probably move over towards the podium.
How many neurologists does it take to move a... Is it clear? Yeah. Brilliant. So I don't have to move it. All right. Yep.
Let's see if it's on there. Is it advancing? Great. Well, I'm honored to have my friend and colleague, Dr. Daniel Clausen here. Dr. Clausen, as you heard during the medical panel, is a neurologist at Vanderbilt University, also movement disorder trained. But even more unique is the fact that he and I grew up right across a few miles from each other in Atlanta, Georgia, but didn't know each other. As you also may imagine, I'm a few years older than he is, and that's one of the major reasons. But then after I had finished at Medical College of Georgia, along came Dr. Clausen at Medical College of Georgia. And then as I went on and became a neurologist and a movement disorder specialist, he did the same thing. And so maybe it was something in the water in Atlanta, Georgia that sort of turns us into the types of docs that hopefully can help out a lot of the folks that are here today. Without further ado, I'm really excited to hear what Daniel's going to tell us today about where we're going with clinical trial work in MSA.
Thank you, David. I always explain it as gene-environment interactions. That's
We may be more related than we think.
So our brothers went to elementary school together. Yeah. So first of all, I just want to thank the organizers for giving me the opportunity to come to New Orleans, and it was really good to hear the story about Hal this morning, and good to see you guys again. The anecdote that I did want to share about Hal was that every time he scheduled a follow-up appointment, he had his LSU baseball or basketball schedule, because he said Vanderbilt's so bad at football, he doesn't want to come up for a Vanderbilt game. So he would schedule his follow-ups based on the LSU schedule, which I thought was great. But so I'm tasked with telling you about the current research and future directions in MSA, and it's a huge task. And I will not be probably as detailed as I could be, but I really hope, like an impressionistic painting, to paint just kind of these broad strokes so you can kind of see the field and where research is going, what kind of studies are being done, how to understand research. When you see it, you get a news release and it says so-and-so may have cured Parkinson's disease, and you read it and you find out that it was done in a mouse, and you really don't worry about Parkinson's in mice very much, and you wonder how on earth is it applicable to me. But so just so you can get some flavor with these ideas. If there's a website that's worth looking at if you're really interested in research for multiple systems atrophy, I would look at the clinicaltrials.gov. That website is updated regularly and gives you a live, this is what's happening in research in the disease that I'm interested in. So for instance, if you go to clinicaltrials.gov, you can type in multiple systems atrophy, and you hit enter and it shows all the clinical trials that are going on. And so it turns out to be a really nice way that you can stay abreast of what's going on and not feel like things are happening without you being aware of it. I'm not recruiting for these trials, except maybe 2 or 3. So if at the end of this you're interested in finding out about some of these trials, I would direct you to clinicaltrials.gov, because it actually shows you who's doing the trials, where they're located, and if it's close to home, you can maybe get involved. From a personal story, I would say that Being involved in clinical research is one way to stay active in your fight against this disease. And a lot of my patients find that by participating in trials, they feel involved and they feel like they're helping the next generation. There may not be a cure while they're around, but it'll help the next generation that fights this disease. And so I've found it both personally and professionally satisfying to be fortunate enough to run a lot of these trials, but also as I go alongside my patients to be involved with them. So what do we need? Well, obviously we need a cure, right? Of course we need a cure. But in order to find out what a cure looks like, we have to know some very key aspects about MSA. Why does it happen? We don't really have a great answer for this right now. We kind of have some clues, but we don't have a very detailed why. Some of the why comes from this protein called alpha-synuclein. I mentioned it earlier, and I'm going to mention it again in this talk. Alpha-synuclein, it's a big word, and if you use it at cocktail parties, people will think you're really smart. But it's basically a protein that gets clumped up in cells. And it's thought that because that protein gets clumped up in cells, the cell doesn't work well. And as the cell doesn't work well, it seems to die. And because it dies, that's why we have the term neurodegeneration. So alpha-synuclein is a protein that gets clumped up in 3 main diseases: MSA, Parkinson's disease, and dementia with Lewy bodies. 3 diseases that present very differently, but share a very similar protein. And so when you read research about Parkinson's disease, to an extent, if it's about alpha-synuclein, it probably has some relevance to MSA. Or if you read about dementia with Lewy body disease and alpha-synuclein, to an extent, it has some information about MSA. So understanding kind of why, it probably has to do with alpha-synuclein. Oh, I got a spelling error in there, and that's just to keep me honest. Why does MSA progress the way it does? Don't have a good answer for that, but we do know over the years that we now have these 2 big lumps of MSA Parkinson's, so there are certain patients that have mostly Parkinsonian features with MSA, and MSA cerebellar, they have more ataxia. And those 2 convenient descriptions are not always mutually exclusive. It's very common that a person might have a little bit of both. But we know that MSA tends to affect a certain type of cell in the brain called the glial cell. And that's kind of a cell that keeps the brain glued together. It's different from a neuron. It's different from other types of cells in the body. But we know that the alpha-synuclein targets glial cells a little differently than it does in any other disease. And what makes the disease so heterogeneous? Why is some patients like Hal present with early Parkinson's features, and he got a bump with cinema, he did okay for a while, and then he goes to develop different symptoms, whereas other people present with walking instability and ataxia, and they go on to develop very different symptoms. We don't have a good answer for that, but those are some of the issues that we struggle with research. What we'd really like is a thing called a biomarker. And that's a word that just means, can I get a test which tells me, A, you have MSA. B, this is how severe your disease is. C, if I modulate that, then I can show that your disease is getting better or changing. So those are the kind of questions that biomarkers give us. We have some that are pretty decent, and I'll show you an example of one later. But a biomarker is another area of research where a group of people will try and collect a lot of different information about patients, and there's going to be a nice talk later about one of the registries that's very important for this disease. And then trying to understand what makes this disease, can we come up with some biomarker that makes this disease more understandable? What's relevant to most of us here is we need better symptomatic treatment. So we need to have medications that improve the lives of patients. So that's kind of a big 64,000 foot view of kind of what we want in research. Every research is different. So I gave you some examples of questions that we need to answer with the MSA, but different studies address different questions. So an observational study is a study that doesn't have an intervention, but understands the characteristics of a disease. Here's an example. If you're involved in an observational study, you may come to see the doctor once a year. And when you come see the doctor, they may take some blood tests. They may do a lumbar puncture. It sounds scary, but it's really not that bad. Trust me. I've had one. You do believe that? You guys are really good. I got some things to sell you. All right. I do a lot of them. You may get some, in the case of MSA, you may get a blood pressure test. You may do some cognitive tests. You may do a motor exam. But that's an example of an observational study where you'll come in regularly and thousands of people around the world will do the same thing, and we'll get some information about what the disease looks like, how it progresses over time. A cross-sectional study may be, I want to understand the difference between people with MSAC and MSAP. I evaluated 10,000 patients, 5,000 had MSAP, 5,000 had MSAC. Here's where the differences were, and this is what it tells us. It's kind of a cross-sectional view. So then we get to the phase 1, 2, 3, 4 studies. Does anyone know what these are? 1, 2, 3. All right, we've got a couple experts in the room. A couple are good. So excuse, if you already know this, excuse me, because I'm going to go through it quickly again. A phase 1 study is simply, I've never given this compound to a human before. I want to make sure it's safe. Okay? Kind of sounds kind of scary, but you have to do it if you're going to advance to coming up with a therapeutic to improve the life of a patient. A lot of trials nowadays have a phase 1 study in a population of interest, and they'll give a certain dose to a population, and they'll go a little higher, and they'll go a little higher, and they'll go a little higher to make sure it's safe. But at the same time, they may get a little data to see if that drug is actually targeting what they think they're hoping it targets. Here's an example. So, for instance, there's a new medication that tries to use an autoimmune way to pull out some of the bad proteins that stick in the brain. And so one of the studies we just did was a phase 1 study. We had a collection of patients, and they came in, and one cohort got, I should say, 2 milligrams, and no one had any side effects. And then the next cohort of patients, next 5 patients, got 4 milligrams. None of them had side effects. The next group came in and got 6 milligrams. None of them had side effects. But as we were doing it, we got brain scans and we did physical exams to see if we were seeing any response to those 1 doses. So phase 1 studies are very important for us because we've got to make sure that what we're giving you is safe, it's not going to hurt you. And it's also nowadays being used to see if we can see what we call target validation. Is the drug that I'm giving you hitting the target that I want to hit? Now, phase 2 studies are really proof of efficacy. So they're usually larger than phase 1. Phase are kind of small, but they really have a hypothesis. If I give this drug, then I will do this. And here's my first pivotal study first study that's going to show it in a large cohort of patients. Phase 2 studies are usually placebo-controlled. That is, one group gets placebo, another group gets a study drug. So you have a chance of getting a sugar pill or a non-medication. And what those studies really are useful for is to show that the clinical target is met or is not met. Phase 3 means that you've done the phase 2 study, you've shown an effect, you're doing it in a bigger population to really nail it down so that you can take it to market. So you can take it and a physician can prescribe it. And so if that happens, and the FDA says, yep, you can do this, you can give this drug for this indication, and this is how you're going to do it, then a company will do a phase 4 study. And usually those studies are, for instance, we found a compound that's going to cure MSA. We also want to see if it cures Parkinson's disease. Or, we've got a drug that works this way. We're going to see if it also works for this indication. So the phase 4 are called post-marketing studies. So those usually have have a different goal. They usually try and change the indication or change the label of the medication. So that's generally how to understand these studies. Now I'm going to take you through a number of different studies that are currently ongoing and give you an example of each one of these so you can see kind of applicably how it works. The key part that was mentioned earlier about MSA is that, it usually takes someone to bring awareness to a disease. And when that person, sometimes a celebrity or someone who's wealthy, brings awareness to disease, it's interesting that there's a lot of interest and sometimes they spur a lot of research. One very applicable example of this, not an MSA but a different population, was a population called a PSP that you heard about earlier. And this businessman really invested a lot of energy and funds into research, and there's now a trial based on his research that is going forward in that population. But I think it's just important to remember that keeping people aware of MSA and aware of the need of a cure really helps drive the interest and expectation that we'll have cures. So here's an example of a phase 1 study. It's called Mesenchymal Stem Cell Therapy in Multiple System Atrophy. And everyone knows what that means, right? Okay, so this brings up another point that I want to make. If you are involved in clinical research and you don't understand what you're doing, that's a problem. So the responsibility of every clinical investigator is to explain to the person who's doing the research what they're doing, what are the risks they're getting involved, what are the potential benefits, and to understand what we call informed consent. And that process occurs through the entire study. So when if you decide to do a research study, and you saw this, the doctor came in and said, you want to do the study, just sign here. It's not obviously the way we do it. You'd come in, you'd read through the informed consent. If you have a hard time reading, someone would read it to you. And you would go through and make sure you understand everything that's going to happen as it happens. What are the risks? What are the benefits? And that's kind of what you'd have. So in this case, this study was being done at Mayo Clinic, where it's pretty cold, the one in Rochester. And in this study, they're doing phase 1, meaning they want to make sure it's safe, and they're giving stem cells that are derived from pluripotent, from other tissue, and they're giving it intrathecally, meaning they're injecting it into the lumbar space. And they're going to see what happens. As I said, phase 1 is safety. So, how many adverse events are there? How severe are they? What type are they? Are they attributed to stem cell therapy or not? What is the intervention dose? Is there more adverse events with higher doses? Do we have to find where the dose is? And as I said earlier, a lot of times with phase 1 studies, they try and also put a little target validation measure to see if there's a signal. And so in this case, they're looking at a multiple system atrophy rating scale, and they're going to evaluate you from the beginning of the study to a year later. And they actually have a placebo arm that was done in a different study called the rifampicin trial, which is an older study that didn't show any efficacy. And they're going to use that as the control. And they're also going to look at MRI scans of the brain, and they're going to estimate rates of atrophy, and they're going to look at cerebral spinal fluid biomarkers. Remember what I said a biomarker was? It's a target of how the disease is progressing and what type of disease it is. They're probably looking at different types of protein, probably alpha-synuclein, from baseline to 2 months. So when you look at a study and you read about it, if you know which phase it is, it tells you kind of where they are with that study, what the study's goals are generally going to be. And as you look at what they're doing in terms of the rating scales, you kind of understand what the group is trying to get from it. So now you know what biomarker is. Now you know what outcome is. Now you know what phase is. So now when you come across more studies, it's going to help you understand where these are. This one's a big one, the Parkinson's vaccine. Who's heard of this one? I get a lot of questions about this in my clinic. So there's a bunch of news stories that comes up about the new Parkinson's vaccine enters trial, first stage of new vaccine, raising a lot of money to get a vaccine. So as I said earlier, alpha-synuclein is that protein that seems to get clumped up in cells. And The idea is if you can pull it out of the cell or get rid of it, could you stop the progression of the disease? Could you halt it where it is? And so here's an example of a study that is starting to look at this. It's called the epitope PD01A and PD03A in patients with early MSA. And of course, when you look at that, you say to yourself, well, okay, what is this? What's going on here? But then you're smart because you went to this talk and you remember I've explained everything, and you say, all right, so it's phase 1, so that means it's what? You're right, because you're awake, thank goodness. Safety. So what are they going to do? So they're looking at the safety and therapeutic activity of an investigational drug that is a vaccine to alpha-synuclein. And as I said, a lot of phase 1 studies now try to put an endpoint in. They try and see if giving the drug changes the trajectory of things. And so in this case, they've got a change in motor symptoms and non-motor symptoms. I told you earlier about biomarkers. Remember, biomarkers are useful in diagnosis, in estimating the rate of change and estimating the severity of disease. And here's an example of one biomarker that we sometimes see in clinic. This is an MRI scan of the brain in an MSA patient. And you can see that, see if this light works here. Do you see how there's this black rim here and here and here and here? You see that? So that's called a putamental hyperdense rim. And so sometimes it's a sign that a patient actually has MSA and not, say, Parkinson's disease. So that's an example. Not everyone with MSA has it, but sometimes when we evaluate patients who have symptoms, we'll get this MRI scan and look at that putamental rim, and it'll, if we find it, it's useful to know that it's MSA and not something else. But I show this picture really to set up the idea of this idea of neuroinflammation and neurodegeneration. So there's a lot of interest now in understanding what happens to the brain when alpha-synuclein clumps up. What does the brain do with that? And there's some suggestion that the brain develops an inflammatory response that is unregulated that causes a cascade of neurodegeneration. So you may see a lot of trials that really focus on halting or modulating the neural inflammation. So it's just thought that just like you have this kind of change in the putamen, that it may be related in some sense to an abnormal inflammatory response in the brain. And some of the cases support this idea. They kind of happen rapidly. The symptoms come on quickly. If you look at some of the mouse models, there's a lot of inflammatory cells, and a lot of cytokines. There's another inflammation that kind of get upregulated. So here's an example of a trial that's got a funny title, AZD 3241. It's phase 2, right, which means they've finished the safety and tolerability study, and now they're looking to see if they give a dose, whether or not it hits its endpoint. Does it change the course of disease? And it's a 12-week safety and tolerability trial looking at biomarker effects of this drug in patients, and there's this myeloperoxidase activity is their outcome measure, really testing the hypothesis that if you modulate neuroinflammation, you can alter the course of disease. So that's an example of another aspect of alpha-synuclein disease. Again, I don't want you to become PhDs and understand neuroscience. I want you to get the big picture of the trials looking at, can we stop alpha-synuclein? Can we get it out of the brain? If we've got it in, and indeed the brain causes inflammation, can we stop the inflammation? Will that change the course of the disease? Those are the kind of trials that you're going to see that are going to come up more and more as we get closer and closer, hopefully, to a cure. We know that, and I'm not going to go through this slide with all the arrows. I put it up just to tell you that it's complex. By now, I hope you realize that it is complex. But I put this slide up really to emphasize the point that we're not sure exactly why alpha-synuclein does what it does. But it seems that it's associated with getting older for some strange reason. And it may be that folks that get alpha-synuclein-related diseases have accelerated aging. That's one idea. And so that's kind of an interesting area of research, is that can you halt the accelerated aging process? And so here is an example of a phase 3 trial. So it finished a phase 2 study. It must have had some kind of target validation, and now they're doing it in a larger study to see if they can get a pivotal outcome to change the way we treat patients. And in this case, they're looking at how fast does MSA progress when you give this compound to stop the aggregation of alpha-synuclein. Remember I told you alpha-synuclein, when it clumps up, that's called a Lewy body, or that's really what's thought to be the problematic. So if you stop it from clumping up, what happens? And so here's an example of a phase 3 trial where they're going to look at this drug, and they're going to say, does a person's motor symptoms, how severe their rigidity, walking, ataxia is, does that stay the same, or does it get a little better, or does it get worse over a year when you give this medication? Because here's an idea. What happens if you have a drug that slows the progression of the disease? That would be very good, right? Because then you could potentially take it and you could live with your symptoms and it wouldn't necessarily get worse. And they're also looking at how atrophy or shrinkage of the brain changes over time, and how iron, which is thought to be a marker of neurodegeneration, changes. I put this, does anyone know what this photo is? All right, so she had potentially a orthostatic hypotension event. We feel her pain. All right, no one got that one. All right, all right. So I put this slide up here as a transition to the last part of research, which is kind of trying to find improvement for symptoms. And not to make you biochemists, but here's the idea. You need norepinephrine to keep your blood pressure up, right? So in MSA, you don't release enough norepinephrine when you stand up. And that's why you don't get constriction of your blood vessels, and that's why you pass out. So there's different ways to increase norepinephrine in the synapse. This is what's called, you can't read it, but it says NET, norepinephrine transporter. There's a couple drugs now that block this transporter and keep norepinephrine hanging around and allow you to increase your heart rate and increase your blood pressure when you stand up. And I'm going to transition my talk about clinical research really now to therapeutic trials, and I'm going to highlight 3 examples of therapeutic trials that are ongoing. The first one is this medicine called atomoxetine. I mentioned it earlier. It's a medicine that's a norepinephrine reuptake inhibitor. Again, the idea is if you block this transporter, you can actually increase norepinephrine, both in the brain potentially and in the periphery, to improve symptoms. There's another medicine, there's a compound called TD9855. It's called Teravance. And then there's a medicine that's on the market now, droxidopa, and there's a phase 4 study, and this is my example of a phase 4 study. So I'm going to go through a couple more slides in particular, just to show you understand how these trials are done and how a person may be appropriate for a trial and how they may not be. Here's an example of the atomoxetine trial. Dr. Shabao is a colleague of mine at Vanderbilt, and she and Dr. Kaufman, I believe, are running this study, and you can hear more about it later. They're looking at transporter blockade with atomoxetine and autonomic failure. So this is how Dr. Kaufman and Dr. Shabao wrote this grant to explain the rationale for why this medication may be useful. They talk about autonomic nervous system and how it's impaired in patients that have autonomic failure. These patients get severe orthostatic hypotension that increases the risk of syncope and falls. And we really only have 2 FDA-approved medicines for this. Midodrine, which binds which is basically an agonist, which stimulates the same receptors that norepinephrine stimulates, and droxidopa, which replaces the norepinephrine that is missing. So what Cynthia thought and Dr. Kaufman thought is, if you actually can improve norepinephrine by blocking the reuptake, could you change blood pressure? And they did a proof of concept study, phase 1 kind of safety and tolerability study, and they gave a single dose of norepinephrine to patients that were on atomoxetine, midodrine, or placebo, just to make sure that the response was as good as midodrine, which was at that time the only FDA-approved medication. And they looked at, does your standing blood pressure increase? And they also looked at orthostatic hypotension-related symptoms, and Dr. Kaufman came up with a really nice scale that quantifies how bad your symptoms are, and they use that as well. And not to show you the details too much, but the red line is atomoxetine, and you can see that early on they saw that atomoxetine, sure enough, increased standing blood pressure, and this really was encouraging because it gave them hope that they could use this medication in certain patients that have this problem. And so they have a hypothesis. And I put this slide in here just to make sure that if you decide to get in a clinical trial, it's worthwhile thinking about what the hypothesis is. And a hypothesis is, I think that by doing this, this will happen. And if that hypothesis isn't clear to you when you do a trial, then it's probably not clear to the investigator who is running the trial. So it's really important for you to understand what the hypothesis is and what you're getting involved in. So here's her hypothesis. If I block the norepinephrine transporter for a long time, and I'm going to use atomoxetine, I'm going to improve the symptoms related to orthostatic hypotension compared to placebo in patients with primary autonomic failure. And so this is the study. And it's also useful when you sign up for a study to know exactly what you're going to be asked to do. Are you going to be getting placebo? Are you going to get study drug? Will that change over time? What are the endpoints? And so this is a figure that actually isn't that complicated, but I'll take you through so you can understand how this study works. So a person would come in and they'd get what's called screening. So they'll be made sure that they're the right patient for the study, and I'll show you what kind of screening measures we'd use in a second. They'd be giving a dose of atomoxetine to find what's the right dose for their response. And then they'd be crossed over into either an atomoxetine trial or a placebo trial. And then, after they've had that for 4 weeks, they'll be switched over into placebo, and the placebo will get study drug. And then, at the end of the trial, you'll be able to say, does atomoxetine improve symptoms, and was that symptom improvement different and when you crossed over to the placebo? And that'll give us really clear evidence that this drug works and the sugar pill doesn't work. So here, when I did the screening, I wanted to show you kind of what, when an investigator runs a trial, they come up with, okay, what's the ideal patient to be in this trial? Not every trial is for everybody, but when you read about the inclusion criteria, they're saying these are the type of patients we want for this study. In this case, they have an age limit, and they want patients that have neurogenic orthostatic hypertension. They define that. They say you have to have at least a 30 millimeter of mercury drop in systolic blood pressure within 3 minutes of standing. So that's the type of patient they want for this study. Now, if you have that, but you have hypersensitive to atomoxetine, you're using other inhibitors of norepinephrine transporter, you have associated symptoms like CHF, a myocardial infarction, heart attack, or renal failure, or you have narrow angle glaucoma, then this study wouldn't be for you because the study medication may affect you in a poor way. So that's when you look at trials, you can look at both inclusion criteria and exclusion criteria to know, is this the right trial for you as a patient? And so in screening, not only will they go through your medication history, then not only will they go through your clinical history, but they'll also take some blood work to look at your blood count, your CMP, your metabolic profile. They'll look at your urine to make sure that it doesn't have any infection or doesn't have any problems with it. If you're female and in pregnancy age, you want to make sure you're not pregnant, so they may do that. Sometimes it's awkward when we have 50-year-old ladies and we say, sorry, we have to do a pregnancy test. And they look at us kind of funny, but that's part of research. They'll get an autonomic function test and these kind of tests. And then Here in this case, you're going to get 2 doses, and you're going to see how you do, and then you're going to get randomized. So that kind of gives you some clarity to how, when these clinical trials are designed, they're designed very methodically, at least they should be designed methodically, so at the end of the trial, they can really answer the question at hand. And in this case, the question is, if I give atomoxetine, do I improve symptoms of orthostatic hypotension, specifically by improving blood pressure? Here's another one that's a similar mechanism, but a different trial design. And the site investigator at Vanderbilt is Dr. Biagioni, and I know Dr. Kaufman's also doing this study. But in this one, they've got this compound that also blocks the norepinephrine transporter, and they want to see, does it improve symptoms in patients with NOH due to these diseases? And just like the one I explained to you, and I just want to show you that not all studies are exactly the same, and the way this study is designed is based on the kind of questions that it wants to be answered. But in this case, it's multi-center, randomized, 2-part, single. The first part is part A, and you get this drug, and you get higher and higher doses until basically you have a increased blood pressure. So you keep on going until you find the sweet spot. And then you go to part B, which is you either get put on that drug or placebo to see if that response is maintained over time. And then the last study I'll talk about is a phase 4 study. And remember, phase 4, the drug's already been approved, and the company typically is looking to see if they can change the label. Can they add another indication? Can they clarify something in the label? It's called a post-marketing study. And this is a study that's done for droxidopa therapy. Droxidopa, again, is Northera. This is another drug that was recently approved for low blood pressure, fun-standing, neurogenic orthostatic hypertension. And here they're trying to answer the question, what is the clinical efficacy of droxidopa over time, as demonstrated by improvements in dizziness? So this is the scale that I mentioned a little bit earlier about the orthostatic hypotension severity scale, which basically says, do you have dizziness, lightheadedness, or the feeling that you're going to pass out? Does that improve over a 12-week treatment in patients with symptomatic NOH? So patients would come in and get 2 weeks of titrations until they get improvement, and then they get washed out. And then a 12-week double-blind placebo-controlled treatment period and a 4-week follow-up period. So again, what we're looking at is this, in this case, phase 4, they're asking the question, is it durable? Does the benefit last over time? So there's a lot to think about, but I hope at the end of this talk you understand a little bit more about the complexity of different types of trials, how a trial is at a different point in terms of its development, and how understanding where along the lines it is development can help you understand and interpret these studies. There's a lot going on. Go to clinicaltrials.gov. Stay in touch with the MSA Coalition, because they're going to make sense of this for you as well. They're going to help you with it. And I would say stay involved. Thank you very much. There's my contact information. Bonnie Black is our nurse at the Autonomic Center. She's wonderful. Cindy Chabal, and there's a phone number. Thanks a lot.
Dr. Clausen, thank you very much. That was an excellent interpretation of where we've been and where we're going, and it really, I think, complements well what we were talking about in the early part of the morning as well. So thank you very much. Dr. Clausen will be available for our question answering panel to follow this. It is now my pleasure to introduce Dr. Ruth Perez. Dr. Perez did her PhD work at the University of Pittsburgh, continued on with some postdoctoral work at Harvard, and now comes to us just from the West over at Texas Tech University. She's going to talk with us today about some novel compounds that were continuing to be used now for MSA. Dr. Perez? Dr. Perez may have stepped out of the room. She did. Well, this will give us some time. We can get the slides set up.
Yeah, Dr. Perez just stepped out, but if you want to take this opportunity, don't leave the room unless you really need to. Just go back and get a snack, and then as soon as and if you have any other questions written down, we'll collect those and get started. So. And I know some people are having to leave to catch planes and that sort of thing. So, as I mentioned before, in case you weren't here, everyone next week should receive a flash drive with all of our information that we've given the whole weekend on it. So we just need to make sure we get your address on the envelopes we'll be passing out a little bit later. And if you need to leave, we will pick up your address from our internet database.
It happens. We can do some more there, too, if you like. Keep you hydrated. So I think they're going to pause for a minute there real quick.
This, there's a pointer there, and then that just advances. Wow. Oh, no, thanks.
If we could start to mingle our way back to our seats, please. Do you want to hold the microphone? Okay. A couple of minutes to get back to their seats. I've not. No. I certainly hope so. Perfect, thank you. It's good to get that out of the way. It's quite all right. All right, folks. If I could ask somebody at the back of the room to go ahead and close the door for us, that would be great. So Dr. Perez is so esteemed, she deserves to be introduced not once but twice. So again, I'm so excited to have had her be able to join us on the team here. As I'd mentioned earlier, she did her initial PhD work at the University of Pittsburgh, then some postdoctoral work at Harvard, and now comes to us from Texas Tech in Lubbock. Am I correct? In El Paso. Thank you. So without further ado, Dr. Perez.
Thank you, everyone. I'm so pleased to be here to talk to you today, and I want to thank you all for staying because we're running kind of late. So today I've got a little bit of good news, at least I hope it's good news, because we're getting some very good results with an FDA-approved drug that might be repurposed for multiple system atrophy. And granted, it's in cell models and mouse models at this time, but because it's already FDA approved, it could be fast-tracked in phase 1 safety trials for MSA, and then if there's any benefit, could move from there. Can't hear me? Okay, thank you. How's that? Is that too loud? Perfect, thank you. So, I'm going to be telling you about novel compounds that may be useful for treating MSA patients. And as a disclosure, I need to tell you that I've taken out a patent on these compounds, and it's for Parkinson's and MSA. And the outline of the presentation, can you see the letter O on that, or is it cut off? Do we need to adjust the screen resolution? Well, I think you can see enough of the other words, but it's the outline of the presentation. I'm going to give you a little bit of background, and most of you already know all of this. about ataxia and MSA and talk a little about the problems that cause it, and again, that alpha-synuclein aggregation in glia and neurons. And then what I'm going to tell you that's really different from everyone else is that I'm going to tell you a little bit about the normal function of alpha-synuclein and why we think it's so important to preserve that normal function. And I'll show you evidence that we have that normal function can be lost when the alpha-synuclein aggregates into clumps. And then we started wondering, might there be a drug that you could use to replace some of that normal function? And we found one that we've been studying. And we've been evaluating it in cell and mouse models. And then I'll wrap up and tell you what the potential benefits may be for MSA. So in sitting in these talks the last few days, I know that everybody knows this, but I'll go through it anyway. What is ataxia? And this is just a generalized ataxia. So ataxia patients have clumsy movements, but it's not because they're weak. It's for another reason. And ataxia can be caused by problems in the cerebellum of the brain, the balance system of the inner ear, or in some nerves outside the brain. And here is a diagram of the brain, and because my slides are off the edge, this region here that you don't see completely is the cerebellum at the back of the brain. And so the symptoms of ataxia can include problems with speech, eye movements, arm and leg movements, and balance problems that can lead to falls. So multiple system atrophy is considered an adult onset progressive ataxia. And it results, of course, from damage to nerves in the brain and body. The symptoms include stiffness of the muscles, jerky movements, lightheadedness, heart rate problems, bladder, sexual, and bowel problems. And of course, most of the MSA that we know about is sporadic, which means there's no genetic known cause. And some people have proposed that it may be caused in part by infections or exposure to toxins. But there are a tiny number of MSA families. In other words, there are some families that do have a genetic cause. And what's been found is that there are 2 alpha-synuclein mutations associated with multiple system atrophy. And this is a model just to show you some of the structural features of alpha-synuclein protein, the protein that is made from that gene. And on the top is just a straight diagram showing the different regions of the protein. It's a small 140 amino acid chaperone-like protein that can interact with a lot of other proteins. But when it gets next to lipids, it can form structure. It's unstructured normally, but when it associates with fats in the cells, it can form this structure that you see here. And alpha-synuclein normally is very soluble and soft and fluid, like an uncooked egg white. And so here, this would be normal alpha-synuclein. When it aggregates, it forms a solid clump, like hard-boiled egg white. And so that's the aggregation that we've all been talking about. And the problems in MSA that lead to brain damage are these. So someone earlier in the day had a beautiful diagram, and this recapitulates that. Here is a nerve cell, a neuron, and its long process, the axon. And this is the myelinating glial cell, the oligodendrocyte. And what happens, people think, in MSA is that normal alpha-synuclein can be secreted from the neurons and be taken up into those oligodendroglial cells. And if too much of that gets taken up, it can form aggregates. And when that happens, there are two things going on. You lose that normal myelination that you need to signal between the nerves in the brain. And you also lose important trophic support, these molecules that support the normal health of neurons and glia. And on the bottom, you can see an example of normal brain on the left, and the WM stands for white matter. And you can see there's a lot of white matter there. Those are the axon tracks in the brain. But in an MSA brain, and it's shown here with a different stain, the dark stain is the white matter here, and you can see how reduced it is. There's a lot less white matter. So you're losing the axons and the glia and the neurons in the brain. And the synucleinopathies that people have been talking about are the Parkinson's disease, which on the left are examples of brains with alpha-synuclein pathology. The round globs are Lewy bodies inside the cells and the neurons, and the long pieces are the Lewy neurites, and those are the axons and other parts of the cell, dendrites, that get filled with this alpha-synuclein in Parkinson's disease. On the right is an example of glial inclusions in those oligodendroglia cells. And you can see that they're a little similar in that they're stained for alpha-synuclein. But you also see something here. It's a glial nuclear inclusion in that glial cell. So the alpha-synuclein is aggregating inside the cytoplasm in the cell body of those glia and in the nucleus of those glia. And that causes problems. But we wanted to know, what does an alpha-synuclein normally do? And in work, partly from my lab, we found that it regulates vesicles, these small little packets of neurotransmitter in neurons. And it also regulates insulin secretion from the pancreas. So we have a beautiful paper done with a colleague in Pittsburgh showing that alpha-synuclein's a normal inhibitor of insulin secretion. But it regulates those brain signaling molecules, the neurotransmitters, and it regulates their synthesis, their release, and their uptake. Earlier you saw one figure in the previous talk where they block the norepinephrine uptake. And alpha-synuclein is regulating a lot of this activity in the brain very normally. And another piece of data from my laboratory is that alpha-synuclein is an important normal activator of a protein called protein phosphatase 2A, PP2A. So this is very biochemical, but I'll show you briefly what that would do. So PP2A is an enzyme. It's a protein in all our cells throughout our body that is busy. Okay, here's the protein on the left, and there's an enzyme called a kinase that adds a phosphate group to that protein. And you need a phosphatase to take that off and turn it back to this state. And this is going on in our cells throughout our body, and especially in our brains, to help regulate signaling in the cells all the time. It's a normal function. And what we found was that alpha-synuclein increases PP2A activity. So you have a little bit of alpha-synuclein, a little more, and you get more and more increase in PP2A activity. And we showed this in several of the papers from our lab. But in dementia with Lewy bodies brains, and in fact in this paper from 2012, we looked at Parkinson's brains from duplication and triplication patients with Parkinson's disease, and also dementia with Lewy body brains. And you compare them to the control, and the amount of that PP2A is identical in the control and in the dementia with Lewy body brain. But when we looked at the activity of the PP2A, it's significantly lower in the brains with dementia with Lewy bodies. So we wondered, are there any medications out there that might be able to restore normal PP2A activity? And this is when we found this drug. It's called FTY 720. In work done on cancer research, they showed that it can increase PP2A activity. It's an oral pill. It can enter the brain after you take it as a pill. And it's used now, the FDA has approved this drug to use it to treat multiple sclerosis, which is another demyelinating disorder. Novartis owns the patent for this drug until 2018, and they've already gotten one extension, and they may get another one. So the drug is still under patent for Novartis, and they call their drug Gilenya, which you see here at the bottom. Another name for this drug is fingolimod. And so we worked with a medicinal chemist from New Mexico State University, Dr. Jeffrey Arterburn, and we looked to see if we might be able to create safer or more potent forms of this same compound. And also with Dr. Donald Moss from the University of Texas at El Paso. And we generated two new compounds. The one at the top is FTY 720C2, which has this little tiny C2 moiety added to the drug. And then the one at the bottom is FTY 720 mitoxy, and it has this large, bulky domain added to it. And the nice thing about that domain is it targets the drug to the mitochondria. And the mitochondria are important organelles in cells that are important for normal, healthy metabolism. And so we studied these drugs. We used them in neuronal cells, and we looked to see if they could all stimulate PP2A activity. And so the black square on the histogram is baseline PP2A activity. I think I've lost my pointer. No, there we go. The blue is FTY 720, the parent compound. The FTY 720C2 is in the gray bar, and there's a huge increase in PP2A activity using that drug. And then FTY 720 mitoxy is a lot like the parent compound. It increases activity to almost the same level. And we also studied how these drugs affected metabolism. And we were pleased to see that all three FTYs can enhance the metabolism of the cells that are treated with it. And they also, okay, so here is where we're seeing an increase in metabolism to the three compounds. Here we saw that all three compounds also increase a very protective factor called brain-derived neurotrophic factor. That's a very protective molecule, one of those trophic molecules that the brain loses when you lose a lot of glial cells. And they can increase that factor in these cells. And then we treated cells with pro-inflammatory cytokine, TNF-alpha, and all three compounds could block the toxicity and the neuroinflammation type of result in response to all three FTY720s. And so we took the drugs to mice, and we have alpha-synuclein mice that we showed previously in 2014 that these mice are a pretty good model of early Parkinson's changes, those pre-motor symptoms of Parkinson's disease. And Parkinson's patients also have a lot of problems with gut motility and constipation. And so what you see on the bottom on the left is tissue from the gut nervous system that's been stained for alpha-synuclein. And the tissue has been treated with an enzyme to degrade all of the soluble alpha-synuclein. And you can see there's really light staining in the wild-type mice. And these are very old mice. They were about 18 months old, which is a very old mouse. Whereas the alpha-synuclein mice, there's so much aggregated alpha-synuclein that you can see it in the heavy brown pigment, the stain there. And when we quantified it, there's a significant increase in this Lewy body-like pathology in the neurons of the gut. And so using these mice, we started treating them with FTY720. And we started treating them after the pathology in the gut had already begun. So we checked at 4 months of age, and they already had pathology. And we treated from 5 months until 22 months. And we've just published our paper this past month showing that FTY720 can reduce the synucleinopathy in those gut neurons, and it improves gut motility in the A53T alpha-synuclein mice. And we also showed that it did this in part by increasing brain-derived neurotrophic factor levels, both pro and mature BDNF. And so here are examples of the gut tissue. And if you look here in the FTY720 treated gut, treated with that enzyme to take out all the soluble proteins, there's a little alpha-synuclein pathology. Remember, these mice had already had some pathology when we started treating them. But if you compare that to the placebo mice, these vehicle mice on the bottom, at the same point of time, you can see a lot more aggregation of alpha-synuclein in the gut, in that tissue. And then without treating with that enzyme to take away the soluble synuclein, you can see that alpha-synuclein here in the gut has a very nice, robust distribution in this FTY-treated mouse. And it is co-localized with an enzyme for dopamine synthesis, tyrosine hydroxylase. And if you look at the merge signal, a lot of that signal is yellow. If you merge red and green, you get yellow signal. And that is exactly how the little baby mouse gut looked before the pathology had started. And this mouse is 17 months old. It's had 12 months treatment with FTY720. Whereas its litter mate treated with the placebo, you don't even see co-localization anymore of alpha-synuclein with tyrosine hydroxylase, except when you look at very high magnification, and you can see tiny little regions of yellow overlap indicating in the tissue itself that they had preserved distribution of soluble alpha-synuclein. We blocked the synucleinopathy in the tissue. And then we took some of the tissue and used a biochemical assay called sequential extraction. So we take the proteins out of the tissue and do different extractions. And if you look at the fourth lane here in the vehicle or placebo mouse, you can see a lot of aggregated alpha-synuclein. Whereas if you look at the age-matched FTY720 treated mouse, the gut has essentially no alpha-synuclein aggregation, or just that little bit like we saw up here. There's also a form of alpha-synuclein called phosphoserine 129 phosphorylation, and that is a type of alpha-synuclein common in the Lewy bodies, and it's also abundant in the glial inclusions. And we looked at those levels in these last two extracts, and you can see tons more of the alpha-synuclein that's highly phosphorylated. And that is what helps drive the aggregation of the protein. Something about that phosphorylation makes it aggregate more. We also blocked the constipation in these mice. They had normal gut motility as well. And then one of the reviewers said, but you haven't really proven that brain-derived neurotrophic factor played a major role, that very beneficial molecule, which indeed is increased in people when we exercise. So that's why BDNF and exercise are good things to keep doing and to increase your BDNF levels. And so we actually took young mice at 4 weeks of age. They would never have had pathology yet. And we treated them for 3 months with a blocker of BDNF, brain-derived neurotrophic factor. That's called ANA12. And we treated those mice. These are all litter mates. And we had a group that was on placebo, treated with the blocker of BDNF, or the blocker plus FTY720, or FTY720 alone. And down here, what you can appreciate is that here was constipation, and none of the others were very constipated, except the ones where you blocked BDNF activity in the gut. And this is really important because there are actually clinical trials where patients with slow gut motility have been treated directly with BDNF and then have improved gut motility and less constipation. And what really, really surprised us is if you stop that gut motility, you increase your synuclein pathology. You can see that second lane here with the ANA12 treatment had a huge amount of synucleinopathy, and this is at 4 months of age. These are very young mice that normally would just be beginning to have synuclein pathology, whereas then the placebo mice, they had very little. FTY plus the ANA12 as the control showed that the FTY720 could reduce that aggregation, and the FTY alone has the very best, the least alpha-synuclein aggregation and the best gut motility. So what we think is that we have, last thing, we've also just finished some studies looking at the 2 new compounds. And we tested the compounds for their pharmacokinetics and their metabolism in vivo in mice, working with a contract research organization, Rycerca Biosciences from Ohio. And we were able to show that both of the new FTYs rapidly enter the brain after they're given. So they cross the blood-brain barrier, which is a very important feature for compounds. One of them is oral and one of them isn't, but it could be given in a patch or in drops or nose drops. And we now have evidence that they also do not make any toxic metabolites. The metabolites of the new compounds are nearly identical to the metabolites of the FTY 720, except for one thing. The FTY 720 can be phosphorylated in vivo. And for multiple sclerosis patients, that's an important thing for FTY 720 because then that drug mimics sphingosine 1-phosphate. That's a really big name, but there are receptors on cells called S1P receptors, and the FTY mimics that. And what it does is it causes the lymphocytes to stay in the lymph tissues throughout the body. And for MS, that's really important because that's an autoimmune disorder. So it partially immunosuppresses those patients. And we now have evidence that from this study that our new compounds do not get phosphorylated. And unpublished data are showing that it's also not causing that problem with the lymphocytes. So these new compounds may be even better to study in humans and even better for patients with Parkinson's or MSA. And so this is just a summary slide suggesting that the drug can turn up not just BDNF, but it's able to turn up nerve growth factor, glial cell-derived neurotrophic factor, and by turning up those factors, it inhibits synuclein aggregation. It also can inhibit the accumulation of alpha-synuclein that leads to cell death, inflammation, and those pro-inflammatory cytokines that cause so much trouble in the brain and the gut with these diseases. And so what do we think this means for MSA? We think that FTYs, all three of them might help by stopping alpha-synuclein aggregation, by reducing inflammation, by normalizing and optimizing that phosphatase activity, PP2A, and by slowing or halting the progression of both Parkinson's and MSA. And in fact, we have other unpublished data. With the funding we got from the MSA Coalition, we received a group of mice that are considered a better MSA model. Although this model, believe it or not, there's a wonderful group of researchers who has used this model in Israel and have found that there are some glial problems in these very mice. And so we've looked at those mice, and the cerebellum of those mice have a lot less inflammation, a lot less activation of microglia, which are the cells that clean up damage in the brain. And so we have evidence in these mice and baseline evidence in the MSA mice that this drug could be very useful. And I want to thank the MSA Coalition specifically, and I think on a previous slide you may have noticed Steve Hoy's picture. He's a man in El Paso, a businessman who is suffering with MSA, and this was a lovely photo taken last Christmas in his garden on a rare snowy day in El Paso for Christmas. Doesn't happen all that much. And this is my student Ismael Segura, who is a PhD student working on the project. And we want you to know that we are inspired to make a difference, that we really care, and that we really want to have our work make a difference for all of us, for the families, for the patients. And with luck and good funding, we'll be able to do that. Here is my team from last spring. A lot of these people are students who've moved on, but Javier is still in the lab. He's a postdoc. Lupe does the mouse work. Barbara is doing some of the molecular and cell biology work, and there's Ismail again. And of course, Catherine, Gloria, and Julie have moved on. And then I want to thank my collaborators and the funders, including the MSA Coalition, the Hoy family, my own family, that my father-in-law passed away with dementia with Lewy bodies last year, and we had a fundraiser and have some funding for our research. A kind, dear friend in Pittsburgh, Anna Mae Doyle, has been giving gifts. And then we've had funding from NIH and the Michael J. Fox Foundation. So in closing, also, I'd like to thank you, and I'm available for questions if there's time.
I think we'll hold the questions for the panel, but I'm sure there will be some. Dr. Price, thank you so much for that interesting work. And she had asked me before I walked up there, she said, have you seen the slides? I said no. So I'm excited, as everyone else in the room is, to hear about this groundbreaking work that's happening with the fingolimod compounds. Thank you very much for cluing us all in. Our last presenter up here today is going to be the indomitable Larry Kellerman. Now, many of you in the room know him better than I only met him a little more than 24 hours ago, and he's already made quite the impression on me. I presume that's because he has been an educator for 30 years, and I always appreciated my teachers along the way. Larry's on the board and has been for a couple of years now, and his unique background in education and interest in research is really appreciated by the coalition. He's here today to talk to us about fundraising. Larry. Thank you, sir.
Now, let's see. How do we forward this?
Let's flip this. Let's put it ready for you.
Okay. Good afternoon. Mine is the shorter version of all of the ones you'll have today. And if you're falling asleep, I'll do a tap dance. Hey, Robin, watch yourself. I know why you're clapping. Believe me. Really, what mine is today is to hopefully get you motivated when you leave here to want to raise awareness and funds for MSA research, for MSA treatments, for MSA programs, all those areas that fall under our 4 pillars. And so I'm hoping that when you leave, you'll know why, and you'll kind of know how you might begin the process.
Do we have slides, Larry?
Well, Don had the slides up there. If not, I'll just go over it. There is none.
Let's see. Don, did you know where it was saved in the... It's on a flash drive.
I don't have the flash drive.
Right there.
Where? This? That's my clicker drive.
Oh, well, good. Well, you guys are all finished. We're set for the day. Dang. Yeah, Rob. I will not. Next time you email me, I'm sending you something. I don't know what. Okay, I'll do some stand-up comedy.
It's not in what I have.
Are there any emails? While they're working on this, let me get started so we don't end up wasting time and we can move forward. I'm being asked to do this, even though all of us on the board are trained, we've all been educated. In many cases, we've had the opportunity to learn from some of the professionals through webinars, etc., on how to raise monies and how to motivate people to get others involved, because it's not just us. And In many cases, if you're like I was when Colleen was alive, you get overwhelmed with the caregiving piece, and sometimes you find that there's not more than 24 hours in a day. And since fundraising is going to take away at least a couple of those hours, you can't change the clock and you can't change the way the sun moves. And so the best way to consider it maybe is to begin thinking about friends or people who can help you. Now, the reason why we think fundraising is most important is because of the very things Dr. Houghton has talked about, Ruth Perez talked about, Dr. Clausen's talked about. They use the monies that they are awarded through research grants that have won the hearts and minds of our scientific advisory board, have been past a rigorous review process to take seed dollars to study a particular hypothesis, as Dr. Clausen said, and if that hypothesis turns out to be one that is either proven or at least it looks like it might be something to study further, then those scientists can go out and look for much larger grants through the NIH, through any of the other federal programs. When Don was talking to you last night at the keynote address, he said that we have had a steady increase in the amount of dollars that have been raised by the MSA Coalition. And the slide that we should have, I can demonstrate for you very clearly. You found it? About 30 seconds out. Oh, we're about 30 seconds out. So with what you'll see, I think you'll understand that with dollars, you get better results. This is not one of those areas where money is thrown away. And we know there are many programs like that. I think we could put in comments, or quotation marks, some governmental programs, sometimes private corporation programs. The monies that are raised may end up lining somebody else's pockets, may end up being used inappropriately, may be used to fund projects that don't have a clear objective in mind. With what we try to do with the different approaches that are used, we try to make sure every dollar is used appropriately for what is most important to all of us, raising awareness and helping you all who are caregivers provide the best quality of life for your patients and for the patients to hopefully get some treatments that are going to improve or halt or even turn around the symptoms and conditions they're having. Fundraising is a way to also connect with others. And with fundraising, you have a unique opportunity to meet people that you may not have ever known, people who inside know what they want to do, but don't have a way to express it until you bring up the idea. You bring up that kernel of a suggestion that they then can take home with them and use on their own. While they're getting the slide ready, I'll give you a real short story about our very first fundraiser. Colleen, when she first learned in 2013 she had the disease, went to the national conference in Wisconsin in September of 2013 to convince herself she did not have MSA, and within 10 minutes goes, "Now I know I've got it. There's too many people here that look just like me." Oh. And when we left, started driving home in our convertible with the top down and the sun was making our brain work pretty quickly, she goes, "You know what? We need to do some things to help us and others. Larry, let's talk about having a fundraiser." So we had our first fundraiser in February of 2014. And now I'll shut up. No, I'll move on. Okay. Thank you. And this is this what changes it? Mm-hmm. Oh, is she going to scroll it? Okay. Oh, I haven't. Are you going to scroll it for me?
Apparently.
Okay. This is a team effort. Why and how to raise money. So we're going to go through one at a time and quickly as we can, but to kind of keep it clear. Yay.
I know there's no internet connection. Thank you very much.
So like I said, we want to support our pillars of the MSA Coalition. First of all, encourage research. Second, support. All of you need support today and yesterday. We're hopefully giving you the kind of support that when you leave here you feel a bit better about this very tough journey that you're on, knowing that there are others that are linked with you through the symptoms and through the many issues that all of us face, and I faced, and Colleen faced. We want to build awareness, and awareness is most important, and at the same time, educate. That's the most important piece, is doing the education. So when we go to the next slide, we'll see that we're run by volunteers. So right now, there are only volunteers that do the work that you've seen outside that happened for the 6-7 months before this conference, will happen after this afternoon, and onward. We have passion. I think all of you have seen the passion. Some people say that I'm pretty passionate, and I think probably I am because I've got somebody behind me to kick me in the rear if I forget that I'm passionate. And we are beginning to look at the idea of having an executive director, a part-time executive director to help with grant applications, fundraising, operations. Over the last 4 years, we've funded 27 research grants. This last year, on October 3rd, yes. Good. This last year, we funded 10. We funded 10 with $532,000 of the money that were raised from people like you, your family, your friends, and the many others that are out there. We do it to encourage young researchers who are just coming on board, and we really need them to begin looking at MSA and at synucleopathies and all the issues that come about. We have had in our annual meetings like today, we typically get, right now I would say, and I think we'll have the actual count later today, but there's between 140 and 50 here this year. And we also have about 3,000 people over the last 3 years who have streamed the video, have watched it at home, tuned in to specific sections of it. And then finally, we want to give personal support. And oftentimes that personal support is our support hotline, having materials that we can make available to you without cost, making sure that there's support groups out there and trying to provide you the links to them. And then finally, we want to have outreach. Conventions, congresses, there are each of us given the charge to try to attend at least one meeting or convention or conference that's related to MSA. So it might be the American Association of Neurology, Movement Disorder Society, etc., to represent MSA and to also learn more from those who are there. This shows the curve, and I was telling you, I was just getting ready to say, you can see how the curve is. In 2011, we were here at my elbow. In 2015, we're at my wrist. And in 2016, we'd like to be up here at the top, above my finger. We had 1.02 million raised in 2015. We'd like to move up above the 1.2 million fund that we see here for 2016. Ma'am? Oh. Funding research. More seed studies. We had 10 grants this year. There were 36 that were first given to us in the pre-proposal stage. That was whittled down to 22. And the 16 people who reviewed those and the scientific advisory board that took their suggestions, there probably could have been 3 to 4 more studies that could have been funded if we would have had the money to do so. And so getting that those funds into those people's hands is very important. And the other thing is, once we do that, if next year there's more money, the doctor who got $30,000 and has now begun to see some significant findings and believes that he's got some additional needs and would like to push this a little bit farther, he's got a different question related to the same hypothesis, he'd like more dollars. We would like to be able to help him if his research grant makes it through the process. And then we also want to make sure that people are getting better diagnosis and treatment. The Center of Excellence that you heard about last night is a good idea. It would be great to be able to fund what they do, and with more dollars, we may be able to begin helping them ascertain how good they can be. The key, and this is what I was going to start with, and I'll get to in a bit, but the key is your story. The story is the most important. I have watched so many people who have seen Colleen, have seen the pictures of Colleen, who knew her, who will come to the fundraisers, and because they know what happened to this very beautiful queen, Steve, who has been here, and you've probably met him, he is from Peoria, and his wife, who passed away 4 years ago from MSA, has joined with me in making this next one we're going to have next year available, and he came out to 2 of the 3 that we've had, and his story with what happened with he and Paula is also very powerful. Your network. You all have a network. It's a Facebook network. It's a neighborhood network. It's a relative network. But your network can be most helpful. And your goal always is, we're going to defeat this disease. We've got to defeat MSA. Somebody might come up to you when they hear that you might be planning a fundraiser. And you're telling them, or you're putting it in your Facebook page, and they go, I wondered what I could do, but how can I help? And if you could help me do that, I'd like to be able to jump in and do whatever it is possible that will get those monies into your pocket, bring more people into your fundraiser, or raise awareness. Now, what we have on our Facebook page, or on our website, if you've been to it, I think probably all of you have been. If you look off to the right-hand side, you'll see in those sort of aquamarine boxes, the second one says Start a Fundraiser. And you could go right to there, click, and we have come up with many ideas. We've got resources that are under there that would help you begin a fundraiser. And most importantly, as we move on a little bit in a few seconds, this is the place where this next stage of our fundraising activity will be placed. And that is a fundraiser that has been put into place by CrowdRise, and over the last couple of years has really taken off. And it is a good way for us to raise dollars as well and get more people to become aware of MSA. So when you're getting your story, if you're the caregiver, you're a part of that story. I mean, all of you know how difficult it is and how rewarding it is and how honorable it is to be with that patient that you love and care for so much. Yet, you also have to get that out to the wider audience. You don't want them to think, wow, this guy needs it or this woman needs it, because you want them to say, they're doing a good job. We think that job's worth funding, and we'd like to also help the patient because he or she is helping that patient. You don't want to be afraid to be emotional. You saw last night that it's kind of hard for me not to be emotional because of just the short time that's passed between Colleen's death and now. So you don't want to avoid that emotionalness. That is very important. Have a way to explain the disease. Some people don't know many people, probably way too many people, don't know what MSA is. So you've got to be able to explain it in nice, clear terms, and that's very important. Pictures. I have, I think, about 8,000 pictures on my computer. 5,000 of them are of flowers. The other 3,000 are of fundraisers and my wife and all other things. And the pictures really help say those 1,000 words that we've all heard about. You make a quick video. A quick video would be a great help, and it can be put up, especially on the CrowdRise fundraiser that this is now beginning to push into. A good short video on a CrowdRise site is powerful as well, because somebody can click, they can see what's going on, why it is that they should donate. And then, why is the MSA Coalition a very good to great charity to support? There is on CrowdRise, it's crowdrise.com, easy to get to. There is an MSA group. You can join any of them. You'll see that there are 3 that I've had. Tom Looney's had several. I talked about Tom Looney last night. Maybe some of you, or 1 or 2 of you, have actually done a CrowdRise fundraiser. I'm not sure. And there are others, many others. who have set a goal. They've tried to attain that goal by encouraging others to donate and to maybe share the word with others. You can do it through email, social media, family and friends, classmates and colleagues, clubs and social groups. Classmates and colleagues, to go to that. My wife was a lifelong Peoria resident. When the people in Peoria who saw the stories that we put on television for this last April, they decided they wanted to come to the fundraiser, and some of them were people who had gone to high school with her, had seen that she'd passed, didn't know how to help, and they saw that there was a fundraiser, and let's help. And in CrowdRise, it's the same way. If they see and know that they can help because their friend passed from this very deadly and devastating disease, they're willing to help. And then make sure you network. I didn't know that until I did it the first time, and one of the ladies who was Colleen's angel, and she has 1,100 friends. As soon as I posted it, she picked it up, and suddenly it went from the 125, 150 friends that were on my Facebook page out to 1,200 people, all of whom had the opportunity, if they wanted, to raise or put some monies into the CrowdRise fund. Passionate and unafraid. The unafraid part can be a bit of a problem for some. We're probably almost all naturally shy. Not everybody is like Robin and willing to stand up and clap when something bad is said. Thank you, Robin. But if you are, you still, if you can, stand up and be counted, or have a friend that can do that. Sometimes that is a good help. And also remember, if you start a fundraiser on CrowdRise, you don't want people to log in and see that it's been up there for a short time and there's $0. It's very good that they see that you've made a donation, whether it's 10, 20, 100, whatever it might be. That tells them you have a reason to donate. I think I should join this person in doing so. And then set a realistic fundraising goal. It's got a place for you to do that. The average over the fundraising efforts by people with MSA related fundraisers last year was $2,300. That's a pretty good average. It could be higher, and maybe that's where after this year some of those averages, or that average, will go up. Be persistent. That's probably the toughest thing. I'm that way. If I ask somebody once and I figure I'm this passionate, they saw Colleen, why wouldn't they be this passionate? That doesn't happen. There's too many other things in people's lives, and being passionate and asking again and asking again, it may bug them a little bit, but they're probably glad in the end that you did that, because maybe it just slipped from their mind. Maybe they were not even listening when you said it the first time, and now's the time for them to hear it. And then don't fundraise alone. With Colleen and I, it was angels. We had so many angels that just came in, joined us, got the word out, took the pieces out, helped us find sponsors, helped us find things for our silent auction. And so you don't want to do the fundraising alone. You want to put together a team if you can. There is, just to go with this story, on November 12th, there is a fundraiser in Gorham, Maine, for a patient who has got the disease. And it's being put together and carried out by his wife's co-workers. And they've reached out to the coalition. I've been able to help them with some materials and resources. And they are just as a team. The wife isn't even involved. She, because they saw her hurting and saw what she had to go through, was the motivation for them to start a fundraiser. On November 29th through January 6th, there is the CrowdRise Holiday Challenge. And with the big day being November 29th, which is Giving Tuesday. You know, there's Black Friday, and then there's local shopping. Well, after all that money that you've used to help the Christmas vendors make their dollar and maybe take care of some of Santa Claus's needs, then why not go on the 29th and donate at CrowdRise some monies for MSA Coalition? And if you have a time, birthdays, anniversaries, holidays, that you might want to ask for donations to be placed in, that's a time when people's minds are clicking on the fact that She passed away. He passed away. And I can remember their wedding anniversary. Maybe this is a time I should do it. It's worth, in a very civil and nice way, to put those ideas out, to put that information out, and maybe you'll have people who say, wow, I have to honor her memory or his memory. So it's very good to do that. Last year, the MSA Coalition on the CrowdRise Holiday Challenge raised $174,000. And through that, we had several individuals who had said they would match. They matched with $150,000 in gifts. Now, for those of you who have worked in corporations or big businesses, many times they have matching gifts. And so if you are working for somebody like that and you make a donation, get their form. Have that form available, turn it into the foundation head or the corporate secretary or administrative assistant, asking them to match your gift, and so you get $2 for every dollar you donate. And there are many that do that. Last year we won third place. I think first place is $50,000. Is that right, Don? $100,000. First prize is $100,000, and we won third prize, beating out over 1,000 other charities to get those dollars. And last year, and this was over the whole, 30 days, 45 days, 73 fundraisers, and they averaged about $2,383. What Don was telling me out in the hallway when he was preparing me for this talk is he said, maybe we could go for 500 this year. I think CrowdRise has enough cloud space to put 500 fundraisers on their site, all that say MSA, and all of those getting monies from wherever the dollars might come from, and ultimately maybe raise either the average or raise the amount of dollars that we have gotten. There it is. Gosh, Don, thank you. We're going to raise $1 million. That's what we hope for. And that's just with the CrowdRise holidays. We add that to all the others that have come in throughout the year. I'll give you another example. A couple that was at the 2014 conference this summer, their friends had a fundraiser in Upper New York. They got 3 local bands to play. They put together a host of activities. They honored the lady. Her name is Jackie Vandenberg. And at the end of the day, they'd raised $13,800 that was sent in to MSA Research. People went and heard 3 local bands, had fun, did a number of other activities, and there was monies that could be donated to these very scientists for next year. And the last reason why, put the money to great use so we can defeat MSA. Now, why do I say that? Well, I'm 39. And because I'm 39, I'm going to want to reach 51. And the secretary who cannot be here today, Pam Bauer, she and I were emailing back and forth, and Pam told me what her goal was. Her goal is to defeat MSA before she retires. She's 53. I said 65. That puts me at 51. I don't know if I'm going to be 76, so what can I say? But nonetheless, it sounded like a good goal to strive to attain. So 12 years, if you can help us in 12 years, we'll have a big birthday party, and we can all enjoy whatever it is that we bring to that party. And in the same time, we'll be letting a lot of people know that their patients are going to be better served and feel better and maybe have that cure. So those symptoms that we've been hearing about these last 2 days go this way, and health and quality of life go this way. So I think that's the last slide. Is that correct?
We're done.
We're done. So thank you very much. I look forward to seeing your name on the CrowdRise website or clicking and starting a fundraiser. I'll always be there to help you, and there are others that would help you make sense of what you're doing, get the monies in the right hands, have a little fun, and get some dollars into those researchers' hands. So thank you. Have a good rest of the day and a safe trip home, please.
Larry, thank you very much. What a fitting ending to a fitting opportunity this afternoon for us to hear about the future directions that we're going with the MSA Coalition And it's only with the philanthropy and the important fundraising that we can do all the important things that we want to do. Judy has a couple of things to announce. While she's doing that, I would invite our presenters from this afternoon to come on up, including Lucy, and all four of you would have the chance to sit up here and take some more questions. Thank you.
While they're getting set up, after the Q&A, and then we'll have about a 2-minute formal closing of the thing. But we always end our conferences with a patient breakout and a caregiver breakout. Very informal. Cameras go off, microphones go off. We'll just have caregivers in one corner and patients in the other. If you'd like to join us for that, feel free. We'll have a couple board members kind of moderating. Some people say that that's just the icing on the cake of a good conference. I just don't want you to get out without knowing that we will be doing that, but it'll look like we're closing down. But those sessions are just very, very private. Larry, do you have something else?
He was just motioning that he needs to come up on stage.
I
wasn't going to get him off without it.
Okay. So I'm going to turn it back over to them so we can get to Q&A, but I just want you to know those breakout sessions will occur. Thank you.
Great. Thank you, Judy. Dr. Clausen's coming up with his snacks. So as we've done before, if y'all can come up with some sort of controlled fashion to pass the questions backwards and forwards, I'll join the audience and listen and learn.
Were you collecting the previous ones?
Yeah.
Who wants to start this party?
You.
Really? All right. How's everyone doing? Tired yet? All right. My question is, what do you think? Sorry, I don't have my glasses up here. What do you think the chances of success for? I think it's nilotinib. Nilotinib. In MSA. That's the one with Georgetown. Yeah. Georgetown disaster. Okay. So that's a good example of how important it is to design phase 1 studies well. Nilotinib is a compound that was initially designed for cancer and then repurposed as a chance to prevent the aggregation of proteins in the brain. And in that study, it was a small safety and efficacy study. I think they did it in 12 patients, and they had some CSF, like lumbar punctures. You know, I think from a safety and efficacy standpoint, they didn't see